Pacemaker. The most common nomenclature for pacemaker coding uses a 4-letter code. The first position reflects the chamber that is being paced: O equals none, A equals atrium, V equals ventricle, D equals dual. Both atrium and ventricle are paced. The second position reflects the chamber being sensed: O, A, V, and D, as earlier. The third position corresponds to the response to sensing: O equals none, T equals triggered, I equals inhibited, D equals dual. The fourth position reflects programmability and rate modulation, e.g., O equals none, R equals rate modulation. As an example, a patient with a dual chamber, rate adaptive pacemaker would have a DDDR code. Rate adaptive pacemakers incorporate a sensor that can modulate the pacing rate independently of intrinsic cardiac activity by monitoring physiologic processes such as physical activity or minute ventilation. Mode switching is a useful feature in which the pacemaker mode automatically changes, e.g., from DDDR to DDIR, in response to inappropriate rapid atrial rhythms. This is particularly beneficial for patients with paroxysmal supraventricular tachyarrhythmias, such as atrial fibrillation or flutter, to avoid rapid ventricular pacing during those episodes. Pacemaker syndrome refers to the deterioration of hemodynamics with associated patient symptoms, or a limitation of optimal functional status, despite a normally functioning pacing system. This is observed most commonly with ventricular inhibited pacing but may occur in any pacing mode in which atrioventricular AV synchrony is lost. Patients may experience a sensation of fullness in the head and neck, syncope or presyncope, hypotension, cough, dyspnea, congestive heart failure, or weakness. Physical findings include cannon waves in the jugular venous pulsations and a fall in blood pressure during pacing compared with normal sinus rhythm. Symptomatic AV block of any kind, including Wenckebach, is an indication for permanent pacing. In patients with hypertrophic cardiomyopathy, dual-chamber pacing has been shown to reduce the left ventricular outflow tract gradient and lead to symptomatic improvement in some trials. There is, however, a significant placebo effect from pacing, and other studies have not confirmed clinical benefit. Thus, the American College of Cardiology/American Heart Association guidelines consider pacemaker placement a Class IIB indication in patients with medically refractory hypertrophic cardiomyopathy and significant outflow tract obstruction. Selection of the appropriate mode of cardiac pacing depends on many factors, including the underlying rhythm disturbance, the patient's exercise capacity, and the chronotropic response to exercise. Ventricular inhibited pacing, VVI, inhibits ventricular pacemaker output if a ventricular event is sensed, but it does not sense or pace the atrium. This mode protects against bradycardias but does not restore or maintain atrioventricular AV synchrony, so that AV dissociation is common. In addition, in chronotropically incompetent patients in whom the sinus heart rate does not increase with exercise, this mode does not provide rate responsiveness. These deficiencies may result in the pacemaker syndrome of reduced functional capacity, shortness of breath, dizziness, and fatigue, which can occur in up to 20% of patients with normally functioning VVI pacing. Single-chamber triggered pacing, AAT or VVT, generates an output pulse every time a native event is sensed. As a result, it accelerates the rate of battery depletion. This mode of pacing is not frequently used. Atrial inhibited pacing inhibits atrial pacemaker output if an atrial event is sensed. It does not sense or pace the ventricle. It is an appropriate mode for patients with sinus node dysfunction who have normal AV conduction but should not be used in individuals with AV nodal disease. Dual chamber pacing and sensing with inhibition and tracking, DDD, is typically the preferred mode of pacing for patients with combined sinus and AV node dysfunction, because physiologic pacing reduces the frequency of the pacemaker syndrome and may reduce the incidence of atrial fibrillation, AF. However, no randomized trial has demonstrated any effect of pacing mode choice, DDD versus VVI, on mortality in patients with sinus node dysfunction. In patients with AF, standard DDD or DDDR is not desirable, because p-synchronous pacing is not possible, and sensing of the chaotic atrial rhythm could trigger an accelerated ventricular pacing response. To compensate for this deficiency, DDD and DDDR devices commonly have an automatic mode switching feature that, when AF develops, inhibits atrial-sensed ventricular pacing. Some dual-chamber pacemakers operate with unipolar leads. The metal capsule of the generator serves as the indifferent electrode. This can result in oversensing, in which skeletal muscle potentials result in inappropriate inhibition or triggering of pacing. The lack of pacemaker activity during the pause indicates that the ventricular lead has sensed the electrical activity generated by the arm and chest muscles and has inappropriately inhibited pacemaker output. In cases of suspected oversensing, placing the pacemaker in an asynchronous mode, with application of a magnet, will abolish the symptoms caused by pacemaker malfunction and aid in the diagnosis. Conversion of the lead system to a bipolar configuration frequently eliminates oversensing of myopotentials. Pacemaker malfunction may be manifested by impaired pacemaker output or failure to capture or sense the appropriate cardiac chamber. On the ECG, failure to capture is identified when a pacing spike is present without evidence of subsequent myocardial depolarization, AP wave or QRS complex. This condition can result from an abnormally elevated electrical threshold, lead dislodgement or perforation, impending battery depletion, or circuit failure. Threshold alterations may be due to medications, e.g., Class 1C antiarrhythmic agents, or electrolyte and metabolic abnormalities, including hyperkalemia, severe acidosis and alkalosis, hypercapnia, hypoxemia, and myxedema. Failure to sense can result from lead dislodgement or inadequate initial lead placement, lead insulation or circuit failure, electromagnetic radiation, or battery depletion. Patients with pacemakers should be cautioned about electromagnetic interference that could result in malfunction. An example is industrial strength welding equipment. Close contact should be avoided. Patients with pacemakers should be warned not to lean on or linger near electronic anti-theft devices, situated at the exits of many stores, because pacemaker malfunction has been reported in that setting. Simply walking past or through such devices is not problematic. Cellular telephones rarely interfere with the function of cardiac pacemakers, when they are placed in the normal position over the ear, rather than over the device. They do not pose a significant risk. As a rule, they should not be carried in the breast pocket ipsilateral to the pacemaker. Left bundle branch block morphology is the expected electrocardiographic pattern during standard right ventricular pacing owing to the delay in depolarization of left ventricular myocardium. The presence of the right bundle branch block after right ventricular pacemaker implantation is suggestive of accidental lead placement or migration into the left ventricle. Pseudofusion is present on the surface ECG when a pacing spike does not alter the normal morphology of a superimposed intrinsic QRS complex. This results when a pacing impulse is delivered at the appropriate escape interval into myocardium whose action potentials are in the absolute refractory period owing to slightly earlier intrinsic activation. Pseudofusion can be distinguished from a fusion beat, in which the QRS complex represents the combination of intrinsic ventricular activation and effective pacemaker depolarization, producing a morphology intermediate between intrinsic and paced beats. Patients presented with intermittent failure to capture and intermittent failure to output on the ventricular lead. Lead impedance was greatly elevated. The telemetric measurement of voltage and current thresholds, lead impedance, and electrograms is very helpful in differentiating the causes of pacemaker malfunction. When a pacemaker wire has fractured, both the voltage threshold and the lead impedance are high. In the case of an insulation break, the voltage threshold and the lead impedance are low. In the setting of a dislodged lead, the voltage threshold is high, but the lead impedance is normal. Exit block may occur as the result of an inflammatory reaction at the point of contact between the pacemaker lead and the myocardium. When this occurs, the measured voltage and current thresholds are high but lead impedance is normal. Pacemaker-mediated tachycardia, PMT, is a syndrome of upper rate behavior that occurs when there is intact ventriculoatrial conduction resulting in retrograde P waves. If these retrograde P waves are detected by the atrial sensing circuit, the pacemaker atrioventricular interval is initiated, and a paced ventricular contraction follows, which generates another retrograde P, and so on, generating a perpetual loop. The diagnosis should be suspected in a patient with a dual-chamber device who presents with a paced tachycardia near the maximum tracking limit of the device. It is managed by increasing the post-ventricular atrial refractory period, which prevents atrial sensing of the retrograde P wave. Because episodes of PMT are often triggered by a premature ventricular complex, PVC, some commercially available devices offer automatic extension of the post-ventricular refractory period after a PVC. In general, dual-chamber pacemakers should be used in patients who require sensing or pacing of both the atria and the ventricles. Rate-modulating pacemakers should be used in patients with chronotropic incompetence due to abnormal or absent sinus node function. In patients with tachycardia bradycardia syndrome who developed symptomatic sinus bradycardia with beta blocker therapy, the most appropriate pacemaker mode would be DDDR. Ventricular pacing is necessary here because there is a risk of atrioventricular block due to beta blockers, and the rate modulating function is important because of the abnormal sinus node function. Use of a non-rate responsive, DDD, pacemaker in this patient would most likely result in lower rate pacing most of the time, with inappropriate response to physical activity. In the patients with atrial fibrillation, AF, who complain of dizziness and are found on examination to have a ventricular rate of 30 beats/minute, VVIR pacing is most appropriate. Atrial sensing or pacing is not possible because of chronic AF, and the rate modulating function is necessary because of the evident chronotropic dysfunction. In patients with complete heart block after aortic valve surgery, there is no indication of sinus node disease, and DDD pacing should be sufficient. In patients with symptomatic sinoatrial exit block and junctional escape rhythm, loss of sinus mechanism requires atrial pacing and rate modulation. And there is no evidence of AV block, and ventricular pacing support is therefore not necessary, so the AAIR pacing mode is appropriate. When the pacemaker generates appropriate output but not consistent, effective ventricular depolarization, this is an example of intermittent failure to capture the ventricular lead. Failure to capture most commonly occurs due to dislodgement of the pacemaker lead from the endocardial surface, a complication that usually occurs within the first few weeks after implantation. Modern designs for active and passive fixation of pacemaker leads are associated with a low frequency of lead dislodgement. Failure to capture may also occur due to a lead insulation break, which allows some of the electrode current to dissipate into the surrounding tissues. Even if the lead system is intact and in contact with the myocardium, failure to capture may occur if the pacing threshold required to depolarize the myocardium exceeds the programmed voltage amplitude and pulse duration. This can occur in the setting of the exit block, in which an inflammatory reaction or fibrosis at the electrode-myocardium interface raises the depolarization threshold. The risk of this complication is greatly reduced using a steroid-eluting lead. Pacing thresholds, and the likelihood of failure to capture, may also be increased in the setting of marked metabolic abnormalities, hyperkalemia, or therapy with antiarrhythmic drugs, flecainide. Impending total battery depletion may also result in a sub-threshold pacing stimulus and failure to capture. Total battery depletion usually results in complete failure to output. In patients with a unipolar pacemaker, air in the pacemaker pocket may act as an insulator and reduce the effective pacemaker output, resulting in non-capture. A loose set screw, which helps secure the lead to the generator, is a cause of failure to output, but not failure to capture, and the diagnosis is by consistent ventricular pacing artifacts are seen.